bottom of the screen, that is our 5-minute countdown before we start the actual show. Well, less than 5 minutes now.
Okay.
Good afternoon, everyone, and welcome to Red Alert. Thank you so much for joining us tonight. No, it's not.
In 1967, Delta Sigma Theta Sorority Incorporated established the Delta Research and Educational Foundation as a public charity supporting scholastic achievement, public service programs, and research initiatives focused upon African American women and their families. Today, DREF remains strong, vibrant, and poised to meet 21st century challenges with the same unwavering spirit and dedication the sorority originally envisioned. The charge to realize social and economic equality for future generations of African American women continues as the guiding principle. Since 2017, DREF has received funding from the National Institutes of Health to continue its role as a national community engagement partner to promote the All of Us research program through a community awareness campaign that informs African Americans and minorities about the importance of understanding and participating in biomedical research. The National Health Initiative, conducted by the Delta Research and Educational Foundation in collaboration with Delta Sigma Theta Sorority Incorporated and the National Council of Negro Women, is entitled Research Matters, Creating Possibilities to Achieve Health and Wellness for All of Us. The objectives are to engage, educate, and ultimately enroll African Americans in the National Institutes of Health All of Us 1 in a Million campaign, a national database primarily comprised of diverse and traditionally underrepresented populations. The mission of the All of Us research program is simple. It is to speed up health research and medical breakthroughs by asking 1 million people to lead the way to provide the types of information that can help create individualized prevention, treatment, and care for all of us. The All of Us research program is a part of the Precision Medicine Initiative created during President Obama's administration. Precision medicine is healthcare that is based on you as an individual. It takes into account factors like where you live, what you do, and your family health history. Precision medicine's goal is to be able to tell people the best ways to stay healthy. If someone does get sick, precision medicine may help healthcare teams find the treatment that will work best. This will help give healthcare providers the information they need to make tailored recommendations relevant to people of different backgrounds, ages, or geographic regions. African Americans continue to have some of the highest incidence, prevalence, and mortality rates from chronic diseases such as cardiovascular disease, diabetes, obesity, hypertension, mental health, and HIV/AIDS. Yet we comprise only 5% of clinical trials participants in America. Our focus and objective is to create awareness about how research matters in closing the health disparities gap. DREF seeks the assistance of national organizations, local chapters, sections, community leaders, and organizations to make the All of Us research program a successful endeavor. The influence, leadership, and participation of the aforementioned groups are needed to assist in promoting this groundbreaking opportunity. Individuals, groups, and organizations are welcome to assist with conducting and/or identifying outreach activities. Training, materials, and monetary resources may be available to support groups and organizations with approved collaborations. Please send an email of interest to researchmatters@deltafoundation.net outlining upcoming activities and events in which the All of Us research program can be included. For more information, please visit www.joinallofus.org/DREF.
Good evening, everyone, and welcome to Red Alert. Thank you so much for joining us tonight. My name is Dr. Maria Dixon, and I am the Engagement Coordinator for the DREF Research Matters for All of Us initiative. I'll be also serving as your host and moderator for tonight. DREF, along with our collaborative partners, Delta Sigma Theta Sorority Incorporated and the National Council of Negro Women, are conducting a national health initiative entitled Research Matters, Creating Possibilities to Achieve Health and Wellness for All of Us. The All of Us program is guided by core values that include diversity, inclusion, security, and transparency. We are working to improve healthcare through research. Unlike research studies that focus on one disease group or a group of people, the All of Us program is building a diverse database that can inform thousands of studies on a variety of health conditions and people with healthy lifestyles, which will create biomedical breakthroughs, identify treatments that work best for people for different backgrounds, connect people with the right clinical studies for their needs, and personalized healthcare towards providing the right patient, the right medication, the right dose at the right time. The future begins with you. So, as a part of our commitment to continue to educate and engage the African American community about the importance of biomedical research and maintaining an overall healthy lifestyle, tonight's event is in support of National Red Day, which is annually celebrated on the first Friday in February. A part of the American Heart Association's signature women's initiative, Go Red for Women. Cardiovascular disease is the #1 killer of women, causing 1 in 3 deaths each year. That's approximately 1 woman every minute. One too many. Tonight, we will feature phenomenal women on both sides of this topic. The physician and the patient sharing tips, tools, and testimonies that will transform lives, increase women's heart health awareness, and serve as a catalyst for change to improve the lives of women globally. Throughout the event, please scan the QR code at the bottom of the page here, or type in the bit.ly link that's in the chat section to complete our engagement exit survey. Your responses are very helpful for planning future events such as this one. The code also provides access to our social media platforms, as well as the vanity link to learn more about the All of Us research program and the DREF Research Matters for All of Us initiative. Now you will see a brief video from the American Heart Association.
The morning of the heart attack, it started out, I just felt sick. I felt like I had the flu, and I was just very nauseous, tightening in the jaw.
I was dying.
I was just still in incredible denial. Even though I had read all of the information on Go Red for Women.
Our family history says that this will always be, and once you get on the medicine, this is your life forever. But it doesn't have to be. And that's what the American Heart Association is telling us.
There's a purpose for my life. There's a reason why I had 2 heart attacks in one day and I'm still sitting here.
Small changes, small steps lead to great results.
As a community, a lot of what we do is around food. Talking about some of those things that are internal in the culture, you know, not wanting to sweat because you don't want to mess your hair up. How can you get around that so that you can still work out? And how can we, you know, figure out a way to attack some of those concerns that women of color have so that we can live healthier lives and move and eat healthier?
Everything from this point on should be, I'm going to teach my children how to live healthy. Like, if you can't afford a gym, walk to the park.
My kids and my husband have really adapted to it more than me.
If you want different results, you gotta do things differently. It's about doing things and taking care of the temple that God has given us. If you just follow the guidelines that the American Heart Association has put in place, they've given us the prescription, just follow it. We have a generation to save.
I fight for other women of color. You know, we have one of the highest incidences of heart disease. And so I fight for them, so hopefully they'll see my story like I saw someone else's, and they'll make a change.
Did you know that heart attack symptoms can differ for men and women? But most common symptom for both is chest pain. So women might also have non-chest pain symptoms and less obvious warning signs. So that's why it's crucial to educate yourself about the signs and symptoms of a heart attack. Know your numbers and live a heart-healthy life. So how do I know if I'm having a heart attack? Symptoms in men include squeezing chest pressure or pain, jaw, neck, or back pain, nausea or vomiting, shortness of breath. The symptoms in women are less obvious. They include also chest pain, but not always. Pain or pressure in the lower chest or upper abdomen, jaw, neck, or upper back pain, nausea or vomiting, shortness of breath, fainting, indigestion, and extreme fatigue. So if you are experiencing any of these symptoms, dial 911 immediately. Follow the operator instructions and get to a hospital ASAP. Do not drive yourself to the hospital and try to stay calm as possible. Take deep, slow breaths while you wait for the emergency responders. So many women think they're healthy and they often ignore those less obvious symptoms of a heart attack because they don't think it can happen to them. Well, watch this next story.
I'm Cherie Johnson. I am now a corporate lawyer with McCormick & Company, Inc. I live and die by my calendar. So if something is not on my calendar, then it's not that important. It started about 9 months consistently before I'm fast asleep and I would feel this chest pain, usually between 2 and 3 or so in the morning. I remember describing it as if I had like a stick or something in my chest. So I went to go see my primary care doctor. She took my vitals, she looked at my body type and my weight and my height and said, "You are normal. It's probably just stress. You need to just relax a little bit." My doctor's telling me I'm okay, but I feel like I'm not okay. August 24th, 2018 was the day that changed my life forever. I had a big presentation on that day, and it was a game-changing, career-changing presentation, so I needed to be ready. Took a couple hours off of work the day before, early, came home, decided to garden to relax, and I felt the chest pain again. This time, I felt the chest pain in the day. My husband made dinner that night.
I'm sometimes a little heavy on the seasoning. I'm a southern guy, so I like to overdo it sometimes with the spices.
It was the worst type of indigestion I've ever felt.
After dinner, she mentioned that, hey, my chest is still a little, tight in areas.
I'm nervous. My big presentation's coming up in a few hours. I need to get some rest. And once again, I woke up with this chest pain. This time it was different. My jaw started hurting, and I collapsed. Here I was, ready for my presentation. I didn't have time for a heart attack. I said, okay, look, here's how I'll negotiate this. We'll call 911 after my presentation. The presentation's maybe 2 p.m., but then I also thought it's gonna be rush hour, maybe after dinner. We'll call 911 after dinner. He didn't buy it. He called 911 anyway. And I see my son. He was watching the whole thing. And all I can think about was, I hope he's not scared. And so I looked at him and blew a kiss to him, and then the paramedics wheeled me out. So while I was in the ambulance, they administered nitroglycerin over 15 times. None of the administrations were successful. My veins just kept collapsing. So I asked the paramedics, which hospital are we going to? They said Sinai, and I asked them to please pass me my phone so I can check the Yelp reviews. And I asked about some of the other hospitals, and they said, we're taking you to Sinai. That's the hospital that has the beds. We get to the hospital, the cardiologist said, you are having a heart attack, and we have to operate right now. And I said, hold on a second, my name is Cherie Johnson, because God forbid they had the wrong patient. I'm laying there, and I hear the surgeon say, I had about 98% blockage in my arteries. Plaque wasn't trapped in my arteries, it was particles of my body. That was shocking. That was rare. And the cardiologist shared some information with me. Number 1, you've been having a heart attack for about 18 hours. Number 2, somebody was watching out for you. The 17 or so injections of nitroglycerin that we attempted to give you, just one of them would have killed you instantly because of the type of heart attack that you were having. Number 3, you had less than half an hour to live. The hospital that you wanted to go to just would not have been enough time. When I think about 30 minutes, 30 more minutes meant that I can be here for my husband and for my children. I'm supposed to be here. When I look back on the whole situation, with all of my training and education, I still was ignorant to the fact that men and women experience heart attacks very differently. I just was not aware of the symptoms of a heart attack. And thankfully, others around me who love me were. Throughout all of this process, I'm grateful for American Heart Association, who's given me this platform to be able to share my story.
All right, tonight we are so honored to have the special heart survivor that was featured in this video, Cherie Johnson. Cherie is a Senior Vice President, General Counsel, and Corporate Secretary at W.R. Grace Incorporated. She also serves as Chief Ethics and Compliance Officer at W.R. Grace, a global leader in specialty chemicals company based in Columbia, Maryland. Cherie earned her Bachelor of Science degree in Chemical Engineering with honors at Florida A&M University with her Juris Doctor at the University of Minnesota Law School. She is a proud member of Delta Sigma Theta Sorority Incorporated and a member of boards including Johns Hopkins University Bloomberg School of Public Health, Manchester Bidwell Corporation, College Bound, and Leadership Baltimore. She's a very busy lady. Over the years, Cherie has been recognized by her peers and awarded Top 100 Women of Maryland, Nation's Best Lawyer, Top Lawyer in Maryland, Mayor's Award for Excellence, and most recently, she was selected to serve as an official spokesperson of the American Heart Association. Cherie, her husband Stephen, and their 2 children live in Baltimore, Maryland. Please welcome Mrs. Cherie Johnson.
Thank you very much. I am very proud and happy and blessed to be here.
Thank you for joining us. And absolutely, you are meant to be here. Well, first of all, before we dive into your video, tell me, how are you doing now?
You know what? I'm doing phenomenal. I feel great. I have a wonderful cardiologist that I'm working with, and I am so much more focused on my health. And I think more importantly, I have a completely different perspective on life.
I totally agree. So let's go a little bit deeper into your video. So you stated that you experienced signs at night only, about 9 months prior. You know, you was feeling this chest pain, but it was only at night. So how different were your symptoms during that morning on August 24th? Were did you feel those same chest pains, or what made you say, hey, something's not right, besides, feeling those symptoms at night 9 months prior? And I don't know, did you think it was just indigestion? What were you thinking?
Yes, so I had, as you said, I had been experiencing chest pain for 9 months. And for me, because my life was so busy, I'd been traveling quite a bit. I traveled out of the country quite a bit as well. And during that time period, my sister, who happens to be a doctor, and my best friend, who is also a doctor, I would call them all the time and just say, hey, look, I'm continuing to have this chest pain. It would occur between 2 and 3 o'clock in the morning. I would gone to the doctor, a woman who was my primary care doctor, 5 times. And each time she seemed to be getting more and more annoyed with me. And I'd have my sister on the phone. I'd have, Google pages up and, hey, look, and something is wrong. I'm not feeling good. I have this chest pain. She checked my vitals and said, you know what, you're fine. I didn't say this in the video, but on the last visit, I went to her and I said, after getting coached by my sister, I went to her and I'm like, look, I'm either having a heart attack or I have cancer or something is wrong. I need you to run a test, figure out what test we need to run, x-ray, something. And she said, okay, fine. So she ran the x-ray came back fine, did the EKG, and that came back fine. And then she said, I'm concerned that you're a hypochondriac.
Wow.
And that really shocked me. And so when I did have this next chest pain, that kept replaying in the back of my mind. You know what? Maybe it's all in my head. Maybe it's not. Maybe it is stress. But then I thought, how can it be stress if it was when I was sleeping? And then so that day when I got home, or I came home early and was gardening outside, and I felt it again. This was different because it was during the day and I was active. And so I knew this was not the same thing that was happening before. And maybe my symptoms were getting worse because now it's a very different situation. So, so that's kind of what triggered me to say, okay, I need to come inside. Now, again, I didn't listen to my body, but I came inside and recognized something was going on.
So one thing that sticks out to me is that you were actually being a self-advocate for yourself. That is very important, because a lot of times, there's this stigmatism that Black women can endure more pain, right? But we have to be self-advocates for ourselves and continue to push it, because
Right.
if you hadn't done that and August 24th hadn't happened, Lord knows what could have happened. So
That's right.
Was there anything that caused you to kind of, you had the chest pains, but you really didn't ignore those symptoms, right? You talked to your sister, you talked to, your best friend. Was there anything different from what you were explaining to them that, that information that you got from your primary care provider?
No, and I think to your point about being an advocate, it's really important, right? We know our bodies. We know when
Absolutely.
something is wrong. And surprisingly enough, I did not have a family history of heart disease. I've been the same size and generally the same weight since college. I have low blood pressure. When I say same size, I'm a size 4, right? So I was not checking the boxes of some of the people who would likely be in this category of, okay, hey, you know what, you may be experiencing heart disease or something with your heart. So I think it was even more important for me to be an advocate and to at least come. There was even the 4th visit where I was like, you know what, maybe I'm not going to come in, jeans or sweats or something. I'm going to come professional. So I looked almost like I was going on an interview. I'm like, you are going to listen to me because I'm an educated woman. I have insurance. And so we're going to have a conversation. And that still wasn't enough. And so I thought about, on my drive home, those women who are afraid to raise, to push for themselves. Here it is, I'm pushing for them myself. I had family members and friends who were all behind me on the phone. I had information, and I still was treated as if I was a hypochondriac, right? And
Right.
so that is why I share, and I'm so happy to share this story, because you know your body. And if something is wrong, you keep asking. And if that doctor is not helping you, then you go to another doctor. And that's what I didn't do. I didn't go somewhere else. I just kind of was like, well, goodness, I feel like I'm a pest now. And so I think it's really important. Keep pushing. Go to a doctor that can help you.
Absolutely. When it comes to your own body, you have to be a pest. If nobody's going to
Right.
stand up for you, only you can, right?
Absolutely.
So a couple of other things that really stood out to me. So you were getting ready to make this huge career presentation, life-changing career presentation. You're in the middle of having a heart attack. Kind of walk us through the process of you thinking about, okay, I need to reschedule the presentation. Not only need to reschedule the presentation, you ask them, what hospital are you taking me so I can look up a Yelp review? You know, you're so successful, you're highly educated. Kind of walk us through that. What made you think of everything but, you know, your husband was like, no, I'm going to call 911 and you're going to go to the hospital. You had so many other things on your mind other than, you know, you were actually having a heart attack. And in fact, you was having a heart attack for 18 hours and didn't realize it.
That's
So kind of walk us through what were you thinking?
Yes. And clearly looking back, I wasn't thinking, but in the moment I was like, I have this all planned out and this was not part of the plan, right?
Right.
And I am, you know, I'm driven, I have things going on, but like many women, unless it's built into our schedule, then any disruption is going to be a problem. And so in my mind that day, I had this great presentation. I generally, you know, made sure that I took care of my health and so forth, but it was really more important that everyone else around me was taken care of. And, you know, being a career focused woman, I had to nail it. And so yes, my husband and I argued back and forth. I'm like, look, I can't go to the hospital wearing my bonnet. I got to change my clothes. I'm not going to just be walking up any kind of way. Pack my iPad, pack my computer and the charger, pack a change of clothes. We had a whole long conversation while I'm on the ground, you know, almost passed out. And of course, he's looking at me like, what is wrong with you? The paramedics came and they're administering the nitroglycerin. And again, for me, I rely on reviews. And so you weren't going to have me at some random hospital in the middle of nowhere, as if I got like a gunshot wound or something. No, I need a certain level of care. And the hospital that they were going to take me to, I was not familiar with it. So we needed to check the Yelp. And they didn't give me my phone. So I'm all stressed, like, okay, where are we going? So anyway, we get to the hospital and you know, once I got there, it was just chaos. They were, you know, in complete shock that I was asking questions and so forth. So, but again, up until they cut me open, I'm thinking about everything else. And not it hadn't even registered that I would ever have a heart attack.
Wow. Wow. So because, you know, your husband is a Southern guy, did it ever cross your mind, maybe, you know, after all that seasoning and you were adding on the food, could that have attributed to me having what did it? Okay, let me go back. Did it ever feel like you had indigestion? Or was
Yes.
it just primarily chest pain?
So that was the first sign. The chest pain was the first sign. And I, you know, again thought, okay, you know, it's just the normal chest pain. Now it's just a different part of the day. The second big sign was indigestion. And again, I had an excuse for everything, right? So
Right.
after the indigestion, I was like, okay, I worked for McCormick at the time. My husband, being Southern, sometimes, you know, he can kind of go overboard.
Mhm.
And so so I'm like, yep, that's what it was. But it was terrible indigestion. I'm like, did you drop like the container in the food? Because this is really, really bad. And I took a Tylenol and went to bed. And then in the morning, about 2:00, 3:00 in the morning, I had the chest pain again, which was the same schedule that I had been having it. But this time I felt very weak.
Okay.
And I attempted to get out of the bed, and then that's when I collapsed. I didn't pass out, but I just collapsed because I was weak. And my husband looked at me and he was like, "You don't look well. You look clammy." And then my jaw started to hurt. And the excuse I had for my jaw was maybe when I collapsed, I hit my jaw on the bed. And then I had to use the bathroom. And I also heard that wanting to feel like you have to pee is also a sign. And again, I considered myself, you know, very well educated from a book standpoint, but I never thought to really research or remember the symptoms of a heart attack because I'm like, that's never going to happen to me. So all of those, when I look back, all of those are check, 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 the symptoms of a heart attack.
Right. So, you mentioned that your husband was very adamant about calling 911. You was like, "No, I got a I got a presentation I got to give." But no, thank goodness your husband stepped in and was like, "No, you going to the hospital." So can you tell our viewers how important it is to have a strong family support system?
Yes, yes. Family, friends, someone who can break into your crazy. When I'm kind of, okay, you know what? My presentation's at 2 o'clock. I'm having a heart attack now. In the back of my mind, where he's saying that. Okay. Again, we negotiated after the presentation, after rush hour, after I eat, then I'll go and sit in the emergency room and wait for them to care for me. But having a strong bond with, or just a network of people around you, family, friends, whomever it may be, that can push you and say, look, something is wrong and you need to be seen. Something is wrong. That's what the professionals are for. I'm so glad that I did do that, because if I did not, I wouldn't be here. So my husband always says, I'd rather you go to the hospital and them tell you nothing is wrong than you not go to the hospital and something is wrong. So I had to remember that.
Absolutely. In fact, nearly fatal.
That's right.
You mentioned you had 30 minutes between life and death. So you mentioned in the video that there were particles of your body that blocked your arteries. Oftentimes we think about plaque, we hear about plaque associating with blocking your arteries. Can you tell us what was the official name of the type of heart attack that you were actually experiencing?
Yes. So I did not have any plaque in my arteries. What I had was, and it's actually a very rare set of circumstances and the conditions that got me to this point. Overall, it's called coronary vasospasm, or in some cases, it's also called prinzmetal angina. And what precipitated all of this is I have suffered from what's called Raynaud's. All of my life, as long as I can remember, I would have, I'm going to try to be very simplistic here, but I would have very cold fingers and toes to the point where they would turn blue. And, I've been able to live with it. It's not a problem. I live in Maryland now. I used to live in Minnesota. I just assumed it was because I was in a cold place. That's why my fingers and toes were turning blue. Anyway, in very rare circumstances, that phenomena of my veins spazzing and almost turning blue, causing my extremities to turn blue, it happens in other parts of your body. And it was happening to the arteries leading to my heart. So it was almost as if you would think of a frostbite. When you have frostbite, you lose feelings and you can almost lose your fingers. And that's what was happening inside my body. So pieces of my body almost were breaking off and getting trapped inside of my arteries. So it wasn't plaque. And when the cardiologist, the surgeon opened me up, he was like, what in the world is going on inside of you? And again, it was just one artery that was almost completely blocked. So I later learned that the coronary vasospasms that I have that have led to a heart attack are extremely rare. In fact, it's rare. However, the most types of people that have this symptom or this situation are people of color. More specifically, 8 people of color who are of Asian descent. So of course my husband was like, are you trying to say that you're Asian? So I'm not going there, but it is very specific to people of color. So what has been this journey for me is learning about, what's happening in my body, asking questions, knowing my numbers, and, just really being in tune, because I did not have a lot of family history. And sometimes you may be the first one. But so I'm teaching my children to share what is happening in their bodies, so that we can have a discussion about it. And obviously not be on the side of making them all anxious and nervous, but let's talk about what's happening in your body and to your body, so we can keep an eye out for things that may be unusual.
Absolutely. That's amazing. Before we wrap up, what is what is the message that you would like to tell women out there, especially African American women, about heart health?
Sure. So I have just a few points, and I think we've touched on all of them as we've talked. So the first one is, as you've mentioned, know your numbers, right? Know your body mass index, blood pressure, cholesterol. All those things are helpful. So when you walk into the doctor, whether it's your primary care or, God forbid, if it's in the ER, knowing that information is going to be quite helpful. Make the best food choices, as we saw in the video. I think it has helped me that I try to eat very, very healthy. Things could have gone wrong, even could have gotten worse if I didn't have a healthy lifestyle. Exercising is obviously important. After I had the heart attack, I've since run a marathon. I won't do it again, but I did run a marathon. But I was able to do that because I was active and was focused on exercise before. Find out my family history. And if there's no history, start keeping records, because I may be the first one. Don't ignore the signs, right? I see a note here in the chat. Many of us, particularly Black women, try to be superwoman, right? And I suffer from that. I'm doing really well at work, and y'all gonna see this presentation, whether I gotta come in there with a stent or a heart attack or whatever, y'all gonna get this presentation. And that was just my mentality, right? I'm not thinking about negotiating whether I'm having a heart attack. I'm thinking I gotta nail this because y'all need to see the magic that I'm bringing, right? And we focus on doing things for others, and sometimes we neglect what's happening in our body.
Forget about ourselves. Absolutely.
Yep.
Absolutely.
So the last one I would say is be a self advocate. And we've talked about it, right? Really push for yourself. You are your best advocate. You know what's happening to yourself. Make time. Your life may depend on it. So I am encouraged, empowered. I am intentional with all that I do, particularly around my health, but also around sharing my message so I can touch and help another woman, another Black woman.
Thank God for keeping you and allowing you to share your testimony with us. Again, thank you so much, Cherie, for joining us. You are a true inspiration. And thank you for joining us. Around, we will have some questions later for you later on in the segment. Thank you.
Thank you.
All right, everyone, please watch this next inspirational story.
I told the doctor about the symptoms I was experiencing, and she said, well, maybe it's just stress. Those symptoms came back one night and woke me up out of my sleep. But this time it was not just my arm, or it wasn't just my neck. My chest was bothering me. I had hot flashes. I felt sick to my stomach. And I told my husband something is seriously wrong. I was having a massive heart attack at the age of 40. I remember my husband sitting there, and he was just as scared as I was. The cardiologist says, we have no time to wait. We need to get you back immediately. And they rushed me back. I don't even remember saying bye to my husband. I don't remember words, telling him stuff to tell my children. No goodbyes. Just all of this was new to me. Heart disease doesn't discriminate. It doesn't care about your size. Know your numbers, know the signs, and call 911. Don't die of doubt. By working together with the American Heart Association and Go Red for Women, we will raise awareness and fund critical research that will save the lives of our mothers, our sisters, our daughters, and friends. Open your heart. Let's unite to prevent heart disease and stroke.
All right, welcome back, everyone. We have two beautiful doctors here that will share their perspective on the other side. We have Dr. Chelsea Gongang and Dr. Amber Johnson. Please welcome them to our event tonight, and I'm going to allow them to introduce themselves, starting with Dr. Johnson.
Hello, good evening. My name is Amber Johnson. I am a cardiologist, a general cardiologist. I am at the University of Pittsburgh, where I am an an assistant professor of medicine. I do majority clinical research, and I study things like hypertension, atrial fibrillation, and heart failure. And I'm particularly interested in health equity, so understanding why different patient populations may experience different outcomes. Some of my studies revolve around why women and Black people get different levels of care and different interventions compared with other groups of people. So it's a pleasure for me to join with you tonight.
Thank you for coming. Dr. Gongang?
Hi, my name is Chelsea Gongang. I'm a cardiologist in Raleigh, North Carolina. I'm a non-invasive cardiologist. And what I specialize in taking care of pregnancy and heart disease, as well as women and heart disease as well. A little bit different than my colleague. I work in more of a private hospital-based practice. And I see patients all over Raleigh, Durham, Chapel Hill area. I think that this is an extremely important type of topic because we do see a lot of disparities when it comes to women of color and women in general when it comes to heart disease. So I'm very excited about being here, especially supporting my own sorority as well, Delta Sigma Theta Sorority Incorporated. So it's been an honor.
Again, thank you all so much. It's awesome to have perspectives from the bench to the bedside. And so we're going to talk a little bit more about what that means. But first, can you tell our viewers what made you pursue a career in medicine and specialize especially in cardiology?
Sure, I can start. I knew that when I was in college that I wanted to become a physician. When I was in high school, I knew I wanted to become a physician. And once I got to college, I worked as an emergency medical technician. So I would drive ambulances and I would get to see patients when they were very ill, a lot of them suffering heart attacks. And that was the experience that helped me to realize how vital the cardiovascular system is and how prevalent heart disease is. Everyone had high blood pressure. Everyone was on medications for their heart. And so it helped me to realize how important cardiology is. And once I got to the field of cardiology, I knew it was the right fit for me. And, it's a long road to become a cardiologist, but it's so very rewarding. I particularly like being a cardiologist because as a woman of color, as a Black woman, I get to see a lot of patients who, like Cherie Johnson, perhaps they had other experiences where they didn't feel like they were listened to. And because of the training that I've had, because of the experiences that I've had, I really pride myself in my ability to build a rapport with patients and to understand where the patient is coming from, getting to know the individual. So that I can help to establish therapeutic relationships with my patients.
Awesome.
Absolutely. Completely agree. Actually, I got into probably Amber has a lot to do with one of the reasons why I came into cardiology. So Amber and another one of our close friends and colleagues, LaPrincess Brewer, who is also a cardiologist. I actually met them and when I was in medical school, and they were presenting different research topics at one of our conferences for medical students. And they were in residency at that time. And I was just very impressed. One year I met LaPrincess, and then the next year I met Amber, and I was like, wow, who are these women that are doing this? They're bosses. I love it. And so as in true Delta fashion, you gonna latch on to see where they, and they come from the same program. And so I was like, oh man, I have to make it to that program. And so I worked hard. I talked to both of them, and I came up for my interview, and it was everything I really wanted and expected. And I got a very thorough I guess, basically basis and background in cardiology. I didn't know exactly if I wanted to do cardiology or not. I knew I wanted to do internal medicine, but once I got to residency, it really solidified. I had a huge background in just wanting to help people as well as help our own community, because I saw a lot of the disparities that a lot of things that we've talked about earlier tonight when it comes to people of color. My grandmother had heart disease. She had congestive heart failure from having high blood pressure. And so just being able to remember weighing her in the morning and making sure I wrote down her weight so that she could take it to her doctor's office was my first understanding of how the fluid and salt balances works. And when I'm talking to my patients about those things. And so I think also we don't deal enough with meeting patients where they are and understanding where they're coming from when it comes to the cultural factors that go into taking care of people of color. And so one of the things that we learned a lot in residency, as well as along the way of cardiology and just being a doctor, is being able to meet people the way where they are and understanding the cultural differences. So I did a lot of talks when I was actually in residency and med school about just understanding your patient and not just the disease. You want to be able to know what that patient is going home to, what types of foods they're eating, how are they going to be able to afford the medicine that you're giving them if they don't have any of access to any of that. How are they going to be able to do certain things? And so that's one of the things that I really enjoyed, because I had a really keen sense of being able to see that.
Absolutely. You know, my grandmother too had congestive heart failure, and growing up in the South, from Mississippi, I witnessed this increased incidence of high blood pressure. We put a lot of salt, a lot of seasoning on our foods, and so not, although it may taste well, a lot of people don't realize how much that salt intake can affect our body. And so in that previous video, that patient stated that she was having a massive heart attack. Can you explain what does it mean by having a massive heart attack? Because I've heard of, people having a massive heart attack, but they end up, dying from it. What is a massive heart attack and why is it often lethal?
Absolutely. Amber, you were taking this one, or I am?
Sure, I can take it. I could talk about this stuff all day. Yeah, I think this question kind of ties into another topic that we wanted to discuss about what makes a heart attack massive and why may the symptoms be sometimes different in men and women. So in terms of what causes a heart attack, we know it has to do with blood flow to the heart muscle. The heart is like a muscle, any other kind of muscle in your body. It needs blood flow, it needs oxygen. And if it doesn't get that blood flow, then that can cause pain. And what makes it massive is the amount of blood flow that is not going to the heart. There are main arteries that go around the heart. You may have heard of the artery called the widowmaker. That's the artery that goes down the front of the heart. I actually don't like using the term widowmaker because it actually is kind of sexist, right? Like, it's not just men who have heart attacks, it's women too. And so I don't really refer to it as the widowmaker, but it's commonly referred to as that. And so that main artery, if that is the artery that gets blocked, especially if it gets blocked closest to the source of where the artery begins, then that means that a large portion of the heart will not get adequate blood flow. And that's what we refer to as a massive heart attack. You could have smaller heart attacks. So the vasospasm that Cherie, Ms. Johnson had described, or maybe a smaller branch artery, if those types of arteries don't get blood flow, then you could still have what's considered a heart attack, but it may not be consistent with a massive heart attack.
Did you want to comment on that as well?
Yeah, I think that the big thing that we really I agree with everything that Amber was saying when we were talking about this, and how to be able to make sure that people understood it, and the aspect of blood flow, because we were trying to figure out what's the best way to understand how the heart works, depending on not just cholesterol plaque, not just a dissection of the arteries, not just a vasospasm, but basically all those different things equate to what Amber said is if you're not getting blood flow to a large percentage of your heart, then that part is going to die or it is going to suffocate. And when it suffocates, that is going to cause an arrhythmia. And arrhythmias are when you have the heart, instead of it not having a nice squeeze action, it starts to fibrillate. And that's like quivering. And when the heart quivers, it is not producing blood flow to the rest of the body. And that can cause basically cardiac arrest. And when cardiac arrest happens, yes, that's when you could definitely die. And then other times, if you're not getting enough blood flow and you have a massive portion of the heart that is dying, then you can have something called heart failure. And so we always want to be able to distinguish that those things can both happen.
All right. So, I mentioned earlier that, symptoms of heart attack can differ in men and in women. Men aren't the only ones that get heart attacks, right? So why are those symptoms so different? And they're less obvious in women than they are in men.
Yeah, I think that the thing that it's kind of a thing about our history. So in history, research has mainly been geared and targeted at white men. And if it's research that is not going to be harmful, put it that way, like observational research. Now, when it's testing research, we have a whole other scenario when it comes to that, when it's like Tuskegee and things like that. But like observational research and therapeutic research a lot of time has been mainly targeted at men and white men. And so when you're looking at symptoms of heart attacks, they will say the classic or the typical symptoms are what men predominantly have, and that is like chest pain, maybe shortness of breath, that gripping sensation, arm pain, and things like that. Well, that is just because they were the ones that were researched and they were the ones that were studied. So it's not the fact that women are just atypical. It's not the fact that it's just not something that's common. It's just that that's who were studied and that's who wrote the book. For women, basically, I would say that our type of typical symptoms can be the same as men, where you can have chest pain, you can have chest pressure, you can have shortness of breath. All those things, but then we have a little bit of extra symptoms that can end up happening. So you can sometimes have just fatigue. Some women just don't feel well. They'll wake up and just feel very, very exhausted, and they can't really put a finger on it. They just do not feel well. Also nausea, sweating. And it's not like a sweat, like a hot flashes sweat. It's more like a cold sweat, cold, clammy type of sweating that is not related to just exertion or being hot or anything like that. Also, you can have pain in other areas. So both across the chest, as well as in the shoulders and the back of the neck, also in the jaw area. I've had patients that thought they had tooth pain and they've actually gotten teeth pulled, and it was actually angina or chest pain. So being able to be aware of the symptoms of heart disease, to have it in the forefront of your mind, is the first step of making sure we're doing prevention.
Absolutely. When you speak of research is absolutely essential. Like you said, that, oftentimes research is done on a 60-plus-year-old white male. And so, what they may see in that person may not occur in a young African American woman as myself, or a young African American male. So it's definitely important, although we do have those past transgressions, to involve yourself into research. Research leads to major medical breakthroughs. And then there are things that are put into place now that will prevent those things from happening, such as the Henrietta Lacks case or the Tuskegee. So, that's all a part of what the All of Us research program is about. It's including everyone, not just, having the doctors take your samples and they do whatever they want to do with it. You are actually involved in every step of the way during our research process. So, you mentioned those different symptoms. Actually, Miss Cherie Johnson named all those symptoms, and she went to the doctor. She told the doctor, "I'm having X, Y, and Z." That doctor said, "I think you're a hypochondriac." Can you guys speak on that? About that, about going to a doctor and a doctor is ignoring you, telling you, "Oh, we don't see anything wrong with you," and kind of just like brushing her off. Can you guys speak on that patient interaction and meeting that patient where they are?
Yeah, certainly I can talk about that. So as I was saying in my introduction, that's part of the reason why I wanted to become a physician, and particularly a cardiologist, because I know that there are those disparities that exist. And it's really important to have that therapeutic relationship, trusting relationship between the patient and physician. There are some things that patients can do in preparation for a doctor's visit. They can come to the visit well informed, and I would recommend going to the AHA website as a reliable place to get information about heart disease. You can even start at goredforwomen.org, and that will direct you to some resources from the American Heart Association. It's really important to understand your symptoms, how you're feeling, and try and relate them to what others have described as it pertains to cardiovascular disease or whatever organ system, if it's something else. Cardiovascular disease is what we're talking about tonight, but I think it relates to the whole gamut. So once you come to the doctor's appointment and you're well informed and you have a list of questions, even, you write out your questions. Sometimes it's actually helpful to have an advocate with you. So if you have someone who you're related to or that you're friends with who has some healthcare experience, that can help. They may not be a healthcare provider themselves, but sometimes just having somebody with you to help you, to remind you about the symptoms that you're having, or to remind you to ask those hard-hitting questions, it can be helpful. I know it's a little bit challenging nowadays with COVID and limitations and the numbers of people who can be in a room, but these are just some important things to consider when you go for your doctor's appointment. And then if you feel that the doctor is not explaining things well or perhaps not taking you seriously, follow up with questions. Try to do it in a respectful, collegial way. I think sometimes it can be a little bit of a turnoff if you come in too aggressive. I don't think anybody wants to be confronted necessarily or, put in a corner. So I think having a nice collegial relationship, it goes both ways from the point of view of the physician as well as from the patient. And if you don't understand something, ask questions, ask them to draw you a picture. I like it when my patients ask me to draw them a picture because I can draw a little doodle of what the heart looks like or what the blood flow looks like. And that really helps me to explain the physiology to patients.
Absolutely. I think that is very good information. We have to know our warning signs. We have to be educated and have self-advocacy. So for me, one thing that comes to my mind sometimes, a panic attack can be confused with having a heart attack. You have this tightness in your chest and you're like, oh my God, I think I'm having a heart attack. People use that kind of carelessly walking around. I feel like I'm having a heart attack, but indeed they may be having a panic attack. So can you explain the major differences between a panic attack and a heart attack?
Yeah, absolutely. So I think of when we talk about panic attacks and anxiety in general, a lot of patients, especially currently right now that I'm seeing in my practice, just due to the social climate that we're dealing with, as well as from changes in the presidencies, as well as the pandemic, things have been quite challenging when it comes to just overall mental health, anxiety, and stress. And so, what usually an anxiety attack, or we call anxiety, is usually when you are expecting some type of stress to occur. So that is you're about to go and do a speech in front of a crowd. You're about to go and do a play or whatever those things are. You're walking into a bad situation at work or something like that. Those are things that are called just anxiety. You're knowing it's going to happen. What panic attack, what is a little bit different in that is that these usually occur when you are not expecting them. And that's the reason why they're called panic, because you're not expecting something bad or this feeling to occur. So when you are watching your favorite program on TV, when you're sleeping or resting in bed, you're reading a book, you're talking to a family member and laughing about something, that is when panic attacks usually occur. And it's usually from the increased stress that is actually in the background. Not necessarily you're feeling stress at that moment, but in the background of your life, it might be an influx of stress. And so usually what panic attacks are is that they usually only last for a specific amount of time, and they usually happen during rest. Not to say that they can't happen during activity or walking or anything like that, but usually they happen during rest. And when they actually do occur, they usually only last for about 15 to 20 to 30 minutes. And mitigating factors can be able to, or things can be able to actually decrease the feelings that you actually feel during that time. And that is like deep breathing. So we call it the rule of 4, where you inspire for 4 seconds, hold it for 4 seconds, and then expire for 4 seconds. And doing that 4 times usually can end up increasing that vagal tone to be able to lower your heart rate and then lower your blood pressure, as well as making you feel a little bit less anxious. Those things end up going away. So your heart rate might be up, your blood pressure may be up, you have a sense of doom, you're having palpitations and also chest pain, but usually they end up subsiding on their own, or you being able to calm yourself will go away. When it comes to actually angina or chest pain, usually most angina will occur when the patient is doing activities, and it usually does not go away, especially if they continue doing an activity. And so usually rest is the only thing that is going to decrease the chest pain. And then if they're having chest pain at rest, which we call unstable angina, that is not going to necessarily go away without some type of thing that is going to be able to stop it, whether that is nitroglycerin, which opens the blood vessels, or aspirin, taking some chewable aspirin patients will do to be able to allow blood flow to get better through an artery. It doesn't really stop. So those are some of the things that you can be able to decipher between the two. Pain that happens at rest and that goes away on its own after doing some mitigation with just breathing exercises, just being able to think nice thoughts and things like that. That's more of a panic. And then chest pain from actually a cardiac standpoint usually is more related to exercise or exertion. You can mimic that pain, because anything that is reducing the blood flow to your heart, if you get up and start moving around and it gets worse, then that is more of a cardiac in nature.
That was very well explained. Thank you so much, Dr. Gongang. Again, thank you all for joining us. Before we segue into our Q&A section, again, thank you so much, ladies, for providing us that wealth of knowledge. It's very important that we know our bodies and we ask the appropriate questions. These two ladies are definitely know what they're talking about. So again, thank you so much for joining us. All right. So before we segue into our Q&A section, if you haven't done so already, please scan over the QR code or type in the bit.ly link that should be in the chat to complete our engagement exit survey. Again, your responses to our survey are very helpful for planning future events such as this one. Also, that leads to our social media pages where it will keep you informed on future events that we will have coming up soon. Follow us on Facebook, Twitter, Instagram. And if you have any questions or you'd like to know any additional information about the All of Us program, go to www.joinallofus.org/DREF. Or if you'd like to email us, you can contact us at engagement@deltafoundation.net or researchmatters@deltafoundation.net. All right. So we have a few questions for our panelists. And so if we can bring them back up, we do have a question for Ms. Cherie Johnson. Cherie, the first question that one of our viewers wants to know is, what motivated you to become a spokesperson for the American Heart Association, besides being a survivor?
So thank you for the question. Yes, absolutely. Being a survivor was one of the key factors, but the other factor was I wanted to touch people who weren't thinking, who were thinking the way that I was thinking. A heart attack could never happen to me. I don't fit the bill in terms of what I look like physically, how I manage my life. And so I wanted to be able to reach a certain population of people. And then more broadly, I wanted to touch African-American women for all of the reasons that we talked about this evening. So being a survivor and sharing my story is really, really important to me. And it never fails. Every time I share it, I encounter at least one woman who says, yep, you weren't crazy. I can see myself doing exactly what you did in terms of negotiating and having discussions about whether or not I should go to the hospital, because sometimes that's just in our nature. So if I can touch one person and have them think differently about their heart health, then I've made a difference.
Well, you have definitely made a difference, Sora Johnson. You touched me, which led you to being our special guest on this event for tonight. So thank you again so much for sharing your testimony. It is truly, truly an inspiration. All right. So our next question is for both Doctors Johnson and Gongang. Our viewer wants to know, what are some preventative measures that can be taken to prevent cardiovascular disease or a heart attack, especially for those who have a family history?
So I can take that one. And Chelsea definitely can jump in too, since she and I both deal with preventive cardiology. So knowing your personal history is important. Knowing your risk factors is important. Sometimes non-traditional risk factors need to be taken into consideration. So the traditional risk factors are things like high blood pressure, high cholesterol, family history, smoking, tobacco. Those things are the typical risk factors that we think about with relation to heart disease, particularly coronary artery disease, like a heart attack. To know those things, usually you'll have to go to a primary doctor to be screened. You'll have to know what your blood pressure is. You'll have to know what your cholesterol is. You should start getting your cholesterol checked probably in your 20s, especially if you have a family history. Sometimes if you don't have a family history, it's okay to not get screened for cholesterol until you're maybe closer to middle age. But if you do have a family history, then that's all the more reason to get some preventative assessments earlier on. Another, what I would consider a non-traditional risk factor, is if you've had a pregnancy-related complications such as hypertension during pregnancy or diabetes, gestational diabetes, those things put you at risk for developing heart disease later in life as well.
Absolutely.
I say wow because when I was pregnant, I did not have high blood pressure. I had what they call as a clean bill of health. And when I got pregnant, I all of a sudden had high blood pressure. And I'm like, I don't know where this came from. So Chelsea, in addition to commenting on that previous question, can you explain why does that happen? You know, when people who are completely healthy and don't have, you know, anything high blood pressure or any of those associated with cardiovascular disease or you know, until pregnant.
Absolutely. So, yes, we see this quite often. Ever and I both take care of pregnant patients, and the main thing is that there's a lot of different hemodynamic things that change it during pregnancy, and you end up having an increased volume load on your heart because you are now building up a lot more of the plasma that's in your body, and so your heart is having to deal with a lot more stress and stretch on it. And then the hormones that are going along with pregnancy, they are typical that can actually end up increasing the vasoconstriction of your body, as well as that can end up increasing your blood pressure. And so when you have this increase in blood pressure, it can be quite dangerous for yourself and for the fetus. And so it's very, very important, especially in the third trimester of pregnancy, to be making sure that you're monitoring your blood pressure. If you have any risk factors, whether it's obesity, family history of high blood pressure, to make sure that those things are monitored, because it can be quite catastrophic if you are not monitoring those factors. And then after pregnancy, one of the things that I always end up talking with my patients about is because after pregnancy, people always think that preeclampsia or hypertension that's associated with pregnancy has to go away after delivery. And typically that's what we learn earlier in life, but that is not actually the case. A lot of patients actually, even about 6 weeks postpartum, can still have something called preeclampsia. And preeclampsia is still where you have hypertension and protein in your urine. And eclampsia is when you actually can have neurological effects where people can actually have seizures or strokes. And so I definitely tell my patients for weeks after they've delivered to make sure that they are actually taking their blood pressure. I've had even family members and friends of family members and friends myself that I've made sure after delivery, I'm always on them. I'm like, what's your blood pressure? Because the Black mortality and Black maternal mortality is real, and it's something that we really have to be able to address. And so those are some of the big things that go along with pregnancy. I think that also one of the things I wanted to add was that a part of risk factors are also modifiable and non-modifiable risk factors. And so I think the person was asking about how family history really plays a part. And so yes, family history is huge. There are some things we cannot unfortunately change our genetics, but we can change the factors that go along with the genetics to add that second hit that can be problematic and cause things to go awry. And so your modifiable risk factors are the things that you can change yourself. That means making sure that your cholesterol is normal, your blood pressure is normal, making sure you're not overweight, making sure that you are eating healthy foods and exercising. Those are all your modifiable risk factors. The non-modifiable ones are the ones you just can't do anything about, and that's your age, your sex, your family history. I would say that now it depends on who you will talk to. For me, almost all of my patients I will end up doing a regular screening on. If they come to see me for palpitations and they do not have a healthy lifestyle, I will make sure that they are getting screened for coronary disease, even though I don't think that they have coronary disease, and they're probably just, they might develop it later on in life, but the fact that they're at risk, we want to get them earlier on. So I will tell them they need to get their cholesterol checked, and they also need to make sure that they're getting their blood pressure monitored, and that it is going well in that direction, because you don't want to get them when it's too late.
Absolutely. And to add to your point, preeclampsia, I had preeclampsia as well. And my blood pressure was like 200 over 130. I just knew like something is not right. So I definitely agree. It is definitely real. We have one more question that we would like, even if you know, Cherie, and it's, can one be tested for coronary vasospasms?
I'll jump in from a layman's perspective, patient perspective, and obviously I'll let the cardiologist jump in. One of the things that was a challenge, because I also got the question of, well, they conducted an X-ray and they conducted an EKG, and both were negative, but they didn't show any signs, and you still had a heart attack. Well, the type of heart attack that I had, and oftentimes, as far as I understand, you have to have the EKG during the time that I was experiencing the vasospasms, so that they can actually see what is happening. In between that period, my body appeared to be normal. So as far as I understand, you cannot test, but you have to understand what the risk factors are. And one of them, which I did not connect, was my Raynaud's, which has a connection point to coronary vasospasms or coincidental angina. But I am a lay person, so I will let the experts chime in.
Sure, I can make some comments about that. So you're right that coronary vasospasm is hard to detect and is relatively rare. There are a number of patients who present with symptoms of a heart attack, and the gold standard test, the test that really shows us what we need to see, is a coronary angiogram, a heart cath. So when, in Miss Johnson's video where she was taken for what was referred to as surgery, that was probably a heart cath, where the doctor, the cardiologist, will go through an artery either in the wrist or the groin and feed smaller catheters and wires up to the heart, and they inject contrast or dye and take pictures with x-rays, and that allows them to see if there's a blockage in the artery. That is the best, most definitive way to tell if someone is having blockage in their arteries. Vasospasm will behave a little bit differently than the traditional plaque, the plaque rupture or thrombus that we typically see. But that would be one way to determine if someone has vasospasm. Less invasive ways might be, as she mentioned, getting an EKG during the symptoms, or perhaps doing a stress test might be a way to see if there's any abnormal blood flow to the heart muscle. That might not be the definitive answer for vasospasm. Another potential way to perhaps monitor would be if someone wore a heart monitor. So as Dr. Gongang mentioned earlier, your heart can develop different rhythms when you have a heart attack. Similarly, the EKG will change when the blood flow decreases. And so if you're wearing a continuous monitor during a time of symptoms, it will pick up if you're having palpitations, arrhythmia, or changes in the portion of the EKG that lets us know about blood flow.
Yeah, and I think one other portion on that is that the testing that we usually do for coronary vasospasms has really gone out of practice, which is in the cath lab, where we actually give a medication that causes vasospasm. And the thing about it is that it can be quite dangerous, because sometimes you can get to a point where you can't open the artery back up after it's vasospasm. So we don't really use that technique anymore in doing testing for vasospasm. Another way is we also do medication trials. So patients that have a thought process, that we've done others testing and we can't really find the reasoning for the patient having this cyclical type of chest pain, then we'll do things where I've had a patient actually that had coronary vasospasms. It was a young girl that was like in her, I think she's like 26 or 27. And she was having one in the clinic when I was seeing her. And so we got nitroglycerin out. And I gave her some under her tongue, and she felt super better. Now she had a headache afterwards because nitroglycerin will give you a headache, but it took her pain away. And that's one of the tests we do actually, and even in the cath lab, when we're looking to see if you have vasospasm, we'll give intracoronary nitroglycerin to see if that will take the spasm away, and that allows us to be able to see that. So putting patients on like longer acting medications that act like nitroglycerin, or something called calcium channel blockers, which are medications that also help relax the vessel walls and lining, are also ways of being able to non-invasively kind of help manage patients that have possible vasospasm and princemental angina.
And just along those lines, I just want to make a brief comment that I know Ms. Johnson had mentioned that she had the chest pain, that the nitroglycerin wasn't working, and thank goodness it didn't work because it would have killed her. To be honest, I'm not quite sure the reasoning behind that thought process. I've not seen that myself, and as Dr. Gongang explained, nitroglycerin can actually help treat arteries that are vasospasming to help restore that blood flow. So I would have to get some more information about that.
Yes, we can talk offline for sure
to understand why that was the case, because typically that we don't see that. So you definitely were a unique patient, Ms. Johnson.
So unique that she was here to tell her testimony to our viewers. Again, thank you so much, Ms. Johnson, Dr. Johnson, and Dr. Gongang for your inspirational testimonies and your wealth of knowledge that you have shared with myself. You know, now you make me want to go to med school. No, I'm just kidding. I am very informed, more informed than I was prior to this event. So again, thank you all for joining us tonight. We really appreciate you for sharing this important information about heart health.
Absolutely. Thank you. Thank you for having us.
Thank you.
All right. So cardiovascular disease continues to be a woman's greatest health threat, claiming the lives of 1 in 3. That's a third of our mothers, our sisters, daughters, friends, our neighbors, and our loved ones. In the past, clinical studies have been adequately inclusive of women or analyze women-specific heart health data. Yet, that is the best way to improve care and prevent heart disease altogether. We aim to change these statistics. Together, we can save the women we love. The All of Us research program is inviting 1 million people across the United States to help build one of the most diverse health databases in history. We welcome participants from all backgrounds. The program offers genetic testing, which will provide more information about you and your family history. Researchers will use that data to learn about our biology, our lifestyles, our environment, and how they affect our health. This could help them develop better treatments and ways to prevent different diseases. To learn more about the All of Us research program, visit us at www.joinallofus.org/DREF. As we close for the evening, again, please hover over the QR code at the bottom of the screen or type in the bit.ly link in your browser and complete the engagement exit survey. Again, your responses are very helpful for planning future events, such as this one. The code also provides access to our social media platforms, as well as the vanity link to learn more about the All of Us research program and the DREF Research Matters for All of Us initiative. I hope you all were empowered by our inspirational testimonies and the importance of a heart-healthy life. Please follow us on our social media platforms for announcements of our upcoming events for this month and moving forward. And remember, know the signs, know your numbers, and live a heart-healthy life. Please watch this next video. Thank you and have a good night.
I go red because I will continue to live a full life thanks to women's heart research. This is not something to be ashamed of. And if it happens to you, there's a growing support network of people here to help you through that journey.
I am where I am today because
I did not give up, and I stayed strong.
You can do it. There's a will, there's a way.
Being a part of this has helped me to get through this kind of scary process and meet some amazing people and share my story and hopefully prevent this situation from happening to anybody else.
Take action. Knowing something and doing something is completely different. You have to put yourself on your priority list.
Let's unite to prevent heart disease and stroke.